Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer. The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insulet.
Hello, everyone, and welcome to this Medscape education program called Ask the Experts, Best Practices in Using Automated Insulin Delivery to Solve Titration Challenges in People Living with Type 2 Diabetes. And thank you to Insulet, as this program is supported by an independent educational grant. My name is Diana Isaacs, and I will be moderating this session. And I am the Director of Education and Training in Diabetes Technology at the Cleveland Clinic in Cleveland, Ohio. And I am pleased to be joined by Dr. Viral Shah, who is a professor of medicine in the Division of Endocrinology and Metabolism, as well as the Director of Diabetes Clinical Research in the Center for Diabetes and Metabolic Diseases at Indiana University School of Medicine. Now, this program is the second in a three-part series on the use of AID systems in people with type 2 diabetes. In this program, we will discuss how AID systems can potentially improve insulin titration in people with type 2 diabetes, resulting in improved patient outcomes, as well as have positive effects on clinician workflow. So with that, I want to turn it over to you, Dr. Shah, and I'm wondering if you could tell us a little bit about the rationale for AID systems in insulin-treated people with type 2 diabetes.
So I think this is an interesting topic and a topic of great interest to me, that why are we talking about automated insulin delivery in people with type 2 diabetes when you might think that there are a lot of newer therapies like GLP-1 analogs or SGLT2s are in the armamentarium of type 2 diabetes management. And do these people with type 2, despite this therapy, would require insulin? Should we really think about, AID? And so this is a reflection question in front of you to just think about. So I think this is something that I would like to challenge all of us, that I think it's a time for us to think that why are we looking at type 1 diabetes and type 2 diabetes from separate lenses. In my opinion, type 1 diabetes and type 2 diabetes have more similarities than differences. So this is just a commentary that we published in Lancet DE earlier this year. And what we proposed is that, and again, this is based on our scientific understanding of type 2 diabetes progression, that think of this way: we have now stage 4 type 1 diabetes, where you have a stage 1, stage 2, stage 3, and the common understanding is that overall the autoimmune process in type 1 diabetes would lead to a decline in a beta cell function and needing insulin therapy. That's a stage 3 type 1. In a type 2 diabetes, even though it's not an autoimmune, but it's a very similar, here you have an insulin resistance and certain genetic factor to begin with, but then you do progress over time, and the progression is in parallel with the beta cell dysfunction. So I will tell you that no matter how much someone have an insulin resistance, they don't develop dysglycemia or diabetes till there is an enough beta cell dysfunction or a declining insulin production. And so that's why I feel like it's a very similar pathway towards needing an insulin. So in a type 2 diabetes, you might call it a pre-diabetes, which is a stage 2. Remember, it's the same diagnostic criteria, whether it's a fasting plasma to or OGTT, A1C between stage 2 type 1 diabetes and pre-diabetes of type 2 diabetes. So again, very similar. The beta cell function decline is the key. Now, the reflection question about GLP-1 and other therapeutic options that are coming out, they are great options, cardiovascular, mortality reduction, a lot of data. They are the standard of care. They should be started first. However, we have enough evidence to suggest that even with the GLP-1, so for example, SELECT trial, Dr. Stephen Kahn was the first author published in Diabetes Care, and they looked at the progression from a prediabetes or a dysglycemia to a normoglycemia with the use of semaglutide in a SELECT trial compared to the placebo. And what they found, again, it's a published, that over time, the trajectory of the progression between the placebo and a semaglutide remains the same. Of course, you are delaying a development from a prediabetes to diabetes, or having a more regression from a prediabetes to normoglycemia with the use of GLP-1 analog. However, after some time, it's just a delay, not permanently prevention. Okay, so I think that's something that's very important to remember. And so no matter what we can do in type 2 diabetes, it's likely that a lot of people with type 2 diabetes is eventually going to require insulin therapy for their management. Also, I want you to think about that part. I think there is a common notion or misconception, I would say, that the people with type 2 diabetes requires tons of insulin. And that's not true or supported by data. These are not an head-to-head comparison, but I showed you two studies here. One was looking at the claims data in a large US-based claims in people with type 2 diabetes on a multiple daily injection, not basal, multiple daily. So the basal plus bolus. And one study is the T1D exchange. These are people with type 1 diabetes. And if you look at the insulin requirement in units per kilogram of their body weight, it's about 0.7 units per kilogram for majority of the people. Half of the people in type 2 diabetes requires less than 0.7 units per kilogram of their insulin. Okay, that's a lot of people with type 2 diabetes that behave, so requires the insulin in a similar way as people with type 1 diabetes. The insulin variability or the need of change in their insulin is also very similar in type 1 and type 2. Again, we don't have a great head-to-head comparison, but I think if you look at the data in both sides, they look very similar. And so I would say with a fair amount of confidence that 3 out of 4 people with type 2 diabetes needs less than 100 units per day, meaning by that the most commercially available automated insulin delivery systems have a reservoir of about 200 to 300 units, and that means that should be useful in large number of people with type 2 diabetes as well. Also, I think if you think about the outcomes of trial in type 2 diabetes with AID and type 1, they are very similar. And so this is an Omnipod 5 where we compared the data from the pivotal trial in type 1 diabetes and the secure T2D trial in type 2 diabetes on basal and the basal bolus insulin therapy. And what you see here is that a very similar improvement in time in range, very similar improvement in A1C without much change in the time spent in hypoglycemia, meaning by that the AID works. It works equally in people with type 1 diabetes and type 2 diabetes on insulin therapy. So that's where I think I would like to really call for an action for all of us to now start thinking about that. Why are we treating people with type 2 diabetes on insulin therapy way differently than people with type 1 diabetes? I think we need to start thinking about recommending an AID system in type 2 diabetes early so that these people can achieve a good glycemic goal and reduce the complication. And there is a common saying that, it takes about 17 years to really have an evidence to come to the clinical practice. And I think it's all of us now has a task to have that statements proven wrong. And I think, implementing devices early would lead to better outcomes and challenges associated with the insulin titrations that we know that it's problematic in type 2 diabetes. And so this is my proposal of that staging of type 2 diabetes and associated treatment with that part. And I would say that stage 3B means that someone who is now on insulin therapy, I think the AID has a better place in managing type 2 diabetes than multiple daily injections. I think, we all know that part, that if you start someone with the basal insulin, let's say, for example, 10 units of insulin glargine, the patient is going to come back to you after 3 months. In between that now to 3 months, sometimes that 10 unit remains 10 units. You're going to increase that to 15 units. It just takes a long time to optimize the glycemia. And all the data suggests that it takes only less than 1 week to achieve the time in range, which will be maintained over the course of the time in a clinical trial. So pretty easy to start and easy to use in people with type 2 diabetes in achieving glycemic goal. So here are just like a kind of an illustration that AID in people with type 2 diabetes can improve A1C, time in range without increasing time below range. And in my opinion, that's the best way and efficient way to improve glycemia in people with type 2 diabetes on insulin therapy. And this is a very recently published meta-analysis in diabetes care. I'm not going to go over the details. You can look at this reference, you can read that by yourself, but nothing surprising to me. Every single study is a consistent in reporting improvement in time in range, improvement in reduction in the time above range, no change in time below range. And so I think we have now enough evidence, and that's why the ADA of standard of care recommends that. And so I highlighted this in a red because you know that here it clearly says that the AID system is a preferred insulin delivery method compared to multiple daily injection in both people with type 1 and type 2 diabetes on insulin therapy, and level A evidence, meaning by that the evidence is coming from randomized controlled trials. So again, I want to reiterate that there are a lot of benefits with the AID system, and I do understand there are some barriers that I think Diana is going to give you some more details about the practical ways to implement the AID in a clinic. With that, I think it's a perfect segue, Diana. Now I want you to explain to us how to do that in a clinic and efficiently.
I think you so brilliantly definitely demonstrated why we need to be thinking about this for our patients with type 2 diabetes, as many of them will need insulin. I want to ask the audience right now, do you feel confident when discussing the various features of currently available AID systems with your patients with type 2 diabetes? Because if we're going to offer this to our patients, we want to be aware of what systems are out there, what the patients are going to be asked or expected to do to optimize the system. So I want you to really think about it. And if not, don't worry. We're going to present some practical tools for you that will hopefully be able to help. So I think the first step is knowing which systems are out there and which ones are actually FDA approved for type 2 diabetes. So we actually have 5 different AID algorithms with 6 different insulin pumps. However, 3 of the algorithms specifically have been studied in type 2 diabetes and have the FDA approved indication. And that includes the Omnipod 5, the Control IQ Plus, which works with the t:slim X2 and the Mobi, and then the MiniMed 780G. Now, our two other algorithms are the twist and the islet, which admittedly we use off label in type 2 diabetes. Just understand they don't have the FDA indication for that. So next, I have these charts to demonstrate the differences. So you can go through them in more detail. But I think some of the key things to think about are what parameters can be adjusted, what are the goals with each system. So you will notice there's slight differences in terms of what is the lowest target that can be achieved. I think an important one is the CGM integration. Sometimes people don't want to switch their CGMs. Other times that's not an issue for them. Dexcom G6 will soon be phased out, but many of them are compatible with G7 or with Libre. MiniMed has their own sensors, so it is a different sensor. It's the Simplera or the Instinct. Previously, people and some are still using the Guardian 4. The way that they automate insulin is a little bit different. And I think that's important as a clinician that may be helping managing and supporting a person with these systems, because some of them will work off of the existing basal rates, for example. And if they do, then that becomes an important area that you may need to adjust. Versus other systems, they don't use that. When they're in automation, they're not using that. And so, kind of understanding the nuances of what parameters might need to be adjusted can be really helpful. The insulin capacity, so we see, for example, some hold 200 and some can go up to 300. And you saw from Dr. Shaw that actually a lot of people don't need as much insulin as we think, but there are some that certainly do need more and may benefit from that 300 unit. And then I think the on-body feeling of it is very important. There are actually, most of our pumps are tubed pumps, and there's different types of infusion set options. However, Omnipod 5 is a tubeless pump. And so some people may prefer to kind of have that freedom of not having the tubing. And then also it's fully waterproof and everything. And then many can be controlled from a smartphone. So you don't, even if you have a tube pump, you don't necessarily have to pull it out all the time if you can control it from the phone. So then when we get to the two that are the two other ones, the twist and the islet, you can see here a little bit of differences in terms of the lowest algorithm target. One unique thing with the twist is it does work with the Eversense, which is an implantable CGM. Right now, it's the only pump working specifically with that CGM. And then in terms of something to know, like with twist, it's iPhone only. So if someone is like a dedicated Android user, then that may not be the pump for them unless they want to switch. Islet actually doesn't have settings. You connect it to CGM and it just starts automating. And also it has the ability, even though it's a smaller reservoir, it can only go up to 180 units. It can work with pre-filled insulin cartridges, which can sometimes be very helpful for ease of use and filling it. So those are some of the big overall differences. Now, the other thing, of course, that comes into play is cost and coverage, right? And so this will differ depending on someone's insurance. But the other area where it differs is that some pumps are going through DME, which is durable medical equipment, and some are now going through pharmacy. And that's actually a big difference for the patient, because when it goes through DME, that generally means a 4 or 5 year contract with a pump. And if they wanted to switch to another pump that goes to DME, they would have to wait that amount of time or pay a lot of money. With the pharmacy, there's actually no contract. So a person month to month, they pay their copay, and they can, if they want to switch another month and try a different pump, they are able to easily do that. At this time, Omnipod 5 and Twist only go through the pharmacy. We are seeing a push with other pumps that they are trying to go through the pharmacy route. And depending on a person's coverage, they sometimes are going through pharmacy route. And the other thing I'll say is that the cost, depending on someone's plan, sometimes pharmacy is cheaper. Some people have no cost, and sometimes DME is cheaper. And that's where individualizing it and finding out what someone's insurance covers. So overall, there's lots of similarities between systems. They are all hybrid closed loop. And what I mean by that, the hybrid means that the person with diabetes is still asked to do things like put in carbohydrates for their food, or at least announce that they're going to eat a meal. Some, like the iLet, are just meal announcements. The Omnipod 5 actually has a feature of custom foods where you can program like breakfast, lunch, dinner. So we can absolutely simplify this, but there's still usually an expectation of, hey, like you're going to bolus sometimes. Also, the filling it up with insulin and generally changing it out every 3 days, unless you have an extended infusion set, which can be changed every 7 days. And the clinical benefits we've seen with all of the systems, and they're all making real-time adjustments with CGM. Now, when it comes to differences, I think some of the big ones to think about are insulin capacity. So would someone benefit from a larger, maybe that 300 units? CGM compatibility. If someone really wants to try that implantable CGM, or they really have a preference on wanting to continue with their current CGM. The way the system is automated. So some people really like being able to make a lot of adjustments. And if they see they're rising a little at a certain time, they want to know that they could adjust the basal a little bit to affect the algorithm. And others want it like pretty hands off, to be, really let the pump do its thing. I don't need to intervene. And I think ease of use, form factor, it's something people are wearing all the time. Like they want something that they like the look of it, and I think that that's okay. We got to respect that as well. So all in all, there's not a one size fits all, and that's why I think it's so great that we have all of these different options, and we can take into consideration all of these different things along with the person's preferences. I think that's really the key thing. Let them know all of these different options that are out there and what some of the kind of the bells and whistles of each system are. And then we can allow them to really choose and make sure that we're offering all the systems. Or if not, if we don't feel comfortable maybe in our clinic to offer, we can connect them to a clinic that is able to offer, that is knowledgeable on it. And I think even some of these things like the alerts, like some have more alerts or more customizable alerts than others, how often you're going to interact, even the dexterity in the fill process. If you really get into the weeds of these different devices, there's different ways that you fill it up with insulin, and some may be a little easier than others based on someone's dexterity. Now, shared decision making, I think, is critical to all areas of diabetes. And this is an example of a conversation that you might have with someone. I think really starting off showing the different options to a person and working together to find out what their needs and preferences are. And then it's ideal if you can let them touch the system. So if you've got demo devices, so they can really see, like, what is the actual size of this? Like, what am I going to be wearing, or what's going to be attached to my body all the time? I want to understand how that feels on me. And then providing them with a place to go for additional information. And an example is Diabetes Wise. Include the link here, diabeteswise.org. But there's actually an HCP facing version of it, and then a person with diabetes facing version, where they can actually input. It'll ask them questions about their preferences and then kind of guide them to different devices that may suit their lifestyle, and they can go and learn more about each type of device. I never want to like push someone into a certain decision. I want them to feel like they're making a very informed decision. And then the great thing is new tech is always coming out. And especially if someone does go the pharmacy route, or even if they didn't and they started with a DME pump, they generally can switch to a pharmacy pump. And I think we want to reevaluate, hey, maybe this pump worked for you initially, but now you want to try something different. And I think that's great. We should continue exploring those different options. So with that, we want to kind of think about, all right, so how do we actually use these AID systems in people with type 2 diabetes in clinical practice? I mean, I think we know that many people with type 2 diabetes are being managed in primary care, right? Not necessarily in endocrinology. So I'm curious, Dr. Shah, if you can provide maybe any practical guidance on incorporating AID systems into practice.
Yeah, Diana. So I think what we do is that the step number one, I call it, is that it's discussing these options with them, right? I think I I heard you mentioning this, and this is what I practice, is that when you talk about the AID, show them all the demos, because without seeing them, it's hard to know which system is going to be a good fit for them, right? Sometimes, if they decide to go for a one system or other system, I have no preference because it's their choice. The success of the AID depends on whether the patient is going to be using this or not, right? So I think something that they can use it every day is the key. And generally, once the patient decides or selects an AID, we try to initiate that as early as possible, because sometimes what happens is that you got that system, and if there is a long time period between getting that system and training them on a system, you are using that time period that I call that it's a returnable warranty or whatever word that they use it, right? It's between 30 to 90 days for most pumps. And I really want people to use that, get a feeling. And if they don't like it, just return it so that you don't have to pay money and tie up to that part. Once they use it, I don't think that I have seen a significant number of people would saying that I hate that. I think I see the other way around, that most people will be like, why didn't we try this before, right? It's the same thing that we hear again and again. So I think talking to them, going for what they're gonna use the most, and starting it early is the kind of my way of including them in a practice.
I think those are such great points. And I think a lot of people with type 2 diabetes are just not offered this technology. And I find that when I present it to them the first time, sometimes they're taken aback. They're like, what? Wait, I'm a candidate for one of these systems? So sometimes it's like introducing it and then coming back to it the next visit and say, hey, have you thought about this more? And I agree with you in that when someone starts it, they generally want to continue it. I do want to share a little bit about our Cleveland Clinic workflow. So generally, when we have that conversation and we encourage, whether it's endocrinology or the primary care to mention it, and then we're fortunate we do have a great diabetes care and education team that people can refer to go over those different options. We also have a class, and I've seen other systems have classes, like even showing like a recorded class so people can watch it at their own leisure and at least get the right information about the different systems out there. But then having that conversation, that shared decision making, ordering that pump, our diabetes care and education specialists can come up with those settings and train the patients. And usually that's often like a 2-hour visit. It's a little bit longer in that initial visit to just learn all the button pressing and make sure someone feels comfortable. And then generally some kind of that follow-up, a little bit of tweaks may happen in the days after. One of the things that we've done is we started a virtual shared medical appointment for our recent insulin pump starts that have started within the last month or so. And we reinforced a lot of the education with the different types of pumps, like some of the kind of neat features that maybe it's easy to forget about with that one-time training. Also like the treatment of lows and treatment of high blood sugars and all of that kind of stuff. And we continue to we make more adjustments as needed. And then after that, generally it's regular follow-up. I think once you've really optimized a person's settings in that initial time, often people don't need a ton of tweaking unless they have like a major life, a more life-changing event. So with that, kind of some concluding remarks that we want to leave you with before we open it to Q&A are that you heard today about how insulin requirements in people with type 2 diabetes can vary significantly over time. And when you have an AID system, it can adapt to that. It can go up, it can go down as needed. AID systems offer several clinical and practical benefits. We saw improved time in range, reduced A1C, reduced hypoglycemia, and reduced burden of self-management. AID systems can mitigate fear of hypoglycemia, and optimal use of AID systems can be strengthened through effective team-based care, really utilizing who you have on the team, the diabetes care and education specialists, pharmacists, your advanced practice providers, and your physicians. And this can support better implementation and patient outcomes. So with that, we thank you so much, and we really thank you for participating in this event.